Hello, and welcome to the first module of the Healthcare Service Delivery chapter of the MSM Implementation Toolkit, or MSMIT, a tool that offers practical guidance for implementing comprehensive HIV and STI programs for gay, bisexual, and other men who have sex with men. This training is brought to you by MSMGF, the global forum on men who have sex with men and HIV. Let's begin with an overview of the Healthcare Service Delivery chapter so you will know what to expect as you progress through the modules. In Module 1, we introduce the HIV prevention, care and treatment continuum and explain what makes up comprehensive health services. Following Module 1 are a series of 11 smaller modules that introduce the individual components of the HIV prevention, care and treatment continuum. They are divided into two broad groupings. Module 2 contains 7 modules that present combination prevention approaches, and Module 3 contains 4 modules that present care and treatment approaches. In Module 4, we present an overview of a range of HIV continuum service delivery approaches, including clinical, mobile, and community-based models. Before we get into detailed content, here is a quick overview of how this tool presents information in as clear and interesting a way possible. At the outset, we would like to note that in the interest of keeping the language of this tool clear and concise, the term gay, bisexual, and other men who have sex with men is often replaced with the shorthand men who have sex with men and/or MSM. These shortened terms should be understood as representing the rich diversity of gay, bisexual, and other men who have sex with men, including those who do not self-identify as such. This first module introduces both the HIV prevention, care and treatment continuum model. After completing this module, you should have a basic understanding of 1. The major components of the HIV prevention, care and treatment continuum, and 2. Principles to guide planning and implementing health service provision for MSM. With these goals in mind, let's begin. In order to deliver and scale up effective and comprehensive HIV prevention, care and treatment services for gay, bisexual, and other men who have sex with men, a number of stakeholders must collaborate to build a network of different intervention approaches. These groups include government, organizations of MSM, and private sector providers. Although all partners are important, community has a very important role to play in programming. As we have noted elsewhere in this tool, research shows that HIV outcomes are significantly improved when services are community-led and supported. It is vital that country programs take stock of HIV prevention, care and treatment resources and ensure they involve MSM in planning and implementation. The package of services described in this chapter is informed by the 2014 World Health Organization Consolidated Guidelines on HIV Prevention, Diagnosis, Treatment and Care for Key Populations, which establish the importance of combination prevention interventions as well as care and treatment interventions. You can access the guidelines at the link shown here. The guidelines divide services for MSM into two broad categories. They are combination prevention interventions and care and treatment interventions. You can see some examples of each presented here. Combination prevention interventions involve identifying, reaching, testing MSM for HIV, and running HIV prevention programs. Note that the word combination is very important here. Individually, these approaches are not as effective as when they are combined. In Module 2, 7 different combination prevention approaches are presented. Care and treatment interventions ensure that MSM who test positive for HIV gain the earliest access possible to treatment, remain adherent to their treatment regime, and achieve an undetectable viral load. Note that care is not just restricted to physical health, and that mental health and drug and alcohol abuse are also important aspects of well-being. Module 3 presents 4 different care and treatment approaches, including modules on mental health and drug and alcohol use. These two programming categories do not operate independently, but as mutually reinforcing parts of a synchronized whole. Together, combination prevention and care and treatment approaches form what is known as the HIV prevention, Care and Treatment Continuum, sometimes shortened to HIV Continuum. You can see a graphic representation of the HIV continuum here. As you can see, depicted are the essential steps for planning and measuring client flow through prevention, care and treatment services. The continuum begins with estimating the size and locations of men who have sex with men, followed by assessing their risk levels and needs. After this, they are reached with HIV combination prevention products and services. A major aim of the HIV continuum is to encourage uptake of HIV counselling and testing. If an individual is diagnosed with HIV infection, they are immediately referred to care and treatment programs that include antiretroviral therapy, commonly known as ART. HIV-negative individuals are continually re-engaged for regular repeat testing and combination prevention programs. As mentioned earlier, mental health and alcohol and drug use are also important parts on the care and treatment end of the continuum. The continuum is an overview of how effective HIV programming works, but it is also much more. It can be used as an easy-to-understand diagnostic, advocacy, planning and monitoring tool. One example of how the HIV continuum can be used in this way is to map data onto the continuum and analyze it. For example, a program might compare the number of individuals who have tested positive for HIV infection with the number of people enrolled in care. Using the continuum in this way enables local service providers to 1. Identify leaks in the system where MSM are lost to follow up or unable to access critical products and services in the comprehensive package. 2. Analyze the root causes of those gaps. 3. Identify the most effective solutions to improve the system's functioning. And 4. Refine and focus interventions and services to reduce HIV transmission and impact. The work of the continuum does not end with referring MSM infected with HIV to care programs and initiating antiretroviral therapy. In order for this model to work effectively, MSM must be retained in treatment. When a service recipient drops out of the continuum, it is known as loss to follow-up. This is something program implementers should avoid at all costs. Loss to follow-up along the HIV continuum is a major problem globally, especially among MSM. This is because services are either unavailable or stigmatizing. An approach that reaches, tests, treats and retains MSM within the continuum is necessary to meet the proposed UN AIDS prevention target of reducing the number of new HIV infections by 75% to under 500,000 a year by 2020, and the UN AIDS treatment target of 90-90-90 in 2020. The 90-90-90 target means that 90% of all people living with HIV will know their HIV status. 90% of all people with diagnosed HIV infection will receive sustained ART, and 90% of all people receiving ART will have durable viral suppression. UN AIDS has also called for 90% coverage of key populations, including MSM, with combination prevention packages that include condoms, lubricant and pre- and post-exposure prophylaxis. These are presented in detail in Module 2. In order to ground this concept in a concrete example, this is an activity blueprint of what the HIV prevention, care and treatment continuum looks like. It summarizes interventions recommended by the World Health Organization at various points along the prevention, care and treatment continuum. This illustration is intended to give you a general idea of what the HIV continuum looks like in practice. You will be introduced to each component in detail as you move through Modules 2 and 3. Without getting into too much detail now, let's turn our attention to a set of overarching considerations and principles that should inform the planning, design and delivery of all HIV continuum services to men who have sex with men. They are presented here as a list. Keep in mind that these apply to all the combination prevention and care and treatment approaches presented in the next modules. We will go through each of these considerations in a bit more detail. The first principle that should govern MSM service design and delivery is to involve men who have sex with men in healthcare provision. This is an important point that we have mentioned before in other parts of this tool and bears repeating. Wherever possible, community members should be involved in the design, implementation, management and evaluation of healthcare services that are delivered in community or clinical settings. Even in settings where providers have limited or no experience serving MSM, involving community members in service delivery can make a huge difference. Community outreach workers and peer navigators, which we explore in more depth in Module 5, are trained MSM who educate community members, refer them to services and guide them through the experience of receiving healthcare. In addition, the presence of appropriately trained community members as clinic staff will increase service uptake by helping to ensure that services are respectful and acceptable. The second principle that should guide HIV Continuum services is to establish a welcoming environment. In order to provide high-quality care, clients must be welcomed into a safe space by respectful staff and given an opportunity to establish a trusting provider-client relationship. Healthcare providers must interact with additional insight and sensitivity when providing services to men who have sex with men, since they often experience stigma and discrimination when seeking and accessing services. Creating a safe, supportive and therapeutic environment is the first step to providing appropriate care to MSM. And when community feels welcome, they are more likely to come back. The third principle is to learn to interact with clients. Providers must understand how to interact appropriately with men who have sex with men as clients, and how to effectively communicate appropriate health messages to them. A helpful strategy is to train healthcare providers on providing compassionate clinical management of MSM that encourages clients to feel safe, accepted and valued. A variety of high-quality training materials have already been developed by experienced practitioners and can be found easily online. The fourth principle is to understand client fear of disclosing symptoms. Men who have sex with men may develop symptomatic sexually transmitted infections before they are willing to present for care. This is often because of shame or fear that they may be associated with disclosing their sexual behavior or the presence of sex-related symptoms. Clinicians should also be aware that emotional or psychological distress may not be freely disclosed, even though psychological symptoms, including depression, anxiety, and suicidal ideation, are more common among MSM than the general population. Health delivery systems in both community and clinic-based settings should be prepared to address the psychosocial needs of their clients in addition to their physical needs. There is a module focused on this topic in Module 3. Take a moment to check your understanding. True or false? According to the UNAIDS targets for 2020, new HIV infections will be reduced by 75%. The answer is true. By 2020, UNAIDS has set the aim that new HIV infections should be reduced by 75% to 500,000 per year. The fifth principle is to link services to antiretroviral therapy, or ART. Timely linkage to ART is critical to reducing HIV-related morbidity and mortality. When an individual is able to become virologically suppressed, they're able to lead a healthy life, but also have a very low risk of transmitting the virus to others. As ART provision has been brought to scale globally, some programmatic challenges have emerged related to ART adherence and retention in care. This is a problem that service providers should be aware of and also address. Community-led programs can play a role in ensuring early linkage to and retention in care. They also play an important role in assisting with treatment adherence. Module 4 presents a detailed overview of community-led service delivery. The sixth principle that should govern MSM service design and delivery is to take a holistic approach. MSM health should be addressed holistically during a health visit or during follow-up care. This means they should be encouraged to address issues such as nutrition, vaccinations, STI prevention, screening for chronic conditions, and leading an emotionally balanced life. If available, healthcare education programs can be crafted to address self-care from the unique perspectives of men who have sex with men, including information about how to develop healthy coping mechanisms for dealing with minority stressors such as homophobia and heterosexism. A secondary goal of all visits should be to encourage individuals to be proactive with their own health and to gain a sense of empowerment about using clinicians as advisors or consultants. Building stronger partnerships and improve coordination between MSM community programs and mainstream health clinics is another way to holistically address community needs. The seventh principle is to integrate services. Globally, HIV services are often compartmentalized and separated from other healthcare services. Prevention is often divorced from HIV care and treatment sites, which may not be co-located with STI treatment, adherent support or other HIV care needs, which creates a barrier to holistic care. The opposite should happen. Services should be integrated. One way to overcome this is to cross-train health providers to deliver multiple services to a single patient, such as hypertension services, stress counseling, and routine STI screening. Engaging MSM community members as providers and advisory bodies can make service delivery more effective by providing insight and direction. The eighth principle is to keep up to date with expanding knowledge. Staying engaged with up-to-date, evidence-based information allows service providers to offer the most optimal clinical care possible. This includes up-to-date guidelines on the management of chronic conditions associated with HIV infection, ART, and aging. In countries with limited resources, service providers must be creative in finding ways to access information and training. A number of good resources are available online. The ninth principle is to design and organize services for implementation at scale. Achieving high coverage, ensuring high-quality services, and linking to or integrating with HIV, sexual health, and other services requires systematic, standardized approaches. Once established and scaled up, services may be expanded in scope to meet with the broader health needs of men who have sex with men. Before moving on, please consider the questions presented in this self-check and assess your understanding of the information presented in this module. This brings us to the end of the first module in the Healthcare Service Delivery chapter of the MSM Implementation Toolkit. To review, in this module we have introduced the HIV prevention, care and treatment continuum. We also looked in depth at 9 principles that should govern prevention, care and treatment services for MSM. In the next 2 modules, we provide a detailed introduction to combination prevention and care and treatment approaches for gay, bisexual, and other MSM.